Thank you very much. I apologize for the quality of internet connection. Again, many thanks to Dr. Abdullah Shihab, to Dr. Musa Akbar for the kind invitation, and congratulations for this meeting and for this concept, as we do learn a lot from our own complications and from the complications of our colleagues. Abrupt coronary occlusion is something that we encounter sometimes. Fortunately, not very frequently, but when it happens, it's a very frustrating for the operators and very harmful for the patient. I would like to share with you the case of a patient that was presented to our department a few years ago and done by one of our young colleagues, but it's a very teaching case. This is the history of a 58-year-old male with a history of smoking who was referred to our department for anterior non-STEMI. Ejection fraction on admission was normal, 60%. This is his left coronary artery system with a tight lesion of the proximal LAD that you can appreciate here. The distal LAD is diffusely diseased, but the flow is quite acceptable. The right coronary artery is free of any significant disease. So the colleague, he proceeded with the wiring of the lesion and stenting, direct stenting of that lesion, and a drug-eluting stent was placed. This, do you hear me?
Yes, we can hear you. Go ahead.
All right. This is the final result, which looks rather acceptable in the spider view. But the patient, when he was brought back to the CCU, just a few minutes later, he experienced chest pain with ST elevation on the EKG in the anterior leads. The patient was brought immediately back to the cath lab, and this is what was found: stent thrombosis. Of course, operators were thinking, discussion where that stent thrombosis comes from. Is it related to the patient, to the lesion, to the procedure? The theory, it was most likely related to the procedure. And of course, they had gone through all these possibilities of being behind that stent thrombosis. Anyway, they did not look very carefully to what they have done. This is what you have seen few days later, not few days, but 2 days later, when we are reviewing the CDs of all patients of the department. And you can see that on that initial PCI, the wire was out of the LAD. So they have not looked at that part, and they went back with a wire that was in the second procedure also out of the artery. They ballooned, and then they find a way of finding the true lumen, or what looks to be the true lumen, and then stent again the LAD with another DES after ballooning. DES stent overlapping with the initial one. This is the final result. It was not great, obviously, but the operator, the young one, who was called, by the way, somebody else with him, some of other colleagues to help him out, they found that they could not do better, particularly looking at this view where you can see the flow is okay, but the result was not great distally. The patient went back to the CCU where the course was unremarkable, but unfortunately, He has lost some of his myocardium. Ejection fraction was 40% with Q wave on the anterior leads on the EKG. Now, 1 week later, the patient was brought back to the cath lab just to look what was the look of that LAD. And this is what we found. The LAD is open, but a flow distally and that kind of lesion, which looked to us a dissection actually. So the other colleague, who was not the initial operator, he proceeded with a ballooning all over the LAD. He has even opened a diagonal that was lost during the initial procedure with an unacceptable result, but no stenting was performed because he did not find the spot where to stent. This is the final result in another view, and of course, it was a nightmare for the initial procedure for the initial operators. Now, how to manage coronary dissection when you figure out there is a coronary dissection, particularly if it is proximal of the left main, being very careful with the guiding, in engaging, no much contrast injection or gentle injection, because that will make the dissection worse. And probably if you find out about the dissection and bringing back the patient to the cath lab, femoral approach would be probably an easier and probably better for controlling the excess of the coronary artery. Now, wiring is the key part of managing these patients. Do your best to find the true lumen. A delivery requires perhaps would be better, and wiring the distal true lumen and being sure you are in the true lumen before any balloon inflation. Sometimes double wire technique would help. Now, if we are not sure in the true lumen, perhaps the use of microcatheter or over the wire coronary balloon to inject might be an option. But again, we have to be very, very careful with contrast injection. A technique like SIP anti-mole tracking and reentry technique, I don't think that's really very safe in that particular context. It's not a CTU context, it's an ACS, and this might be very challenging. IVUS, of course, can help, although it's not always necessary. OCT the same. It will probably make the procedure complex if you use these devices and if you don't go into the true lumen. So the take-home message from this case is coronary dissection, sometimes difficult to visualize, is a common cause of abrupt coronary occlusion. Finding the true lumen is absolutely key for a bailout successful procedure, and initial complications not well managed, as in this case, will generate other complications that will be even more difficult to manage. And just remember that this kind of complications does not happen only to beginners. Thank you very much for your attention.